Your expertise and experiences are invaluable contributions to our collective learning. The conference theme, Nuclear Medicine, Expand and Boundaries. I extend my warmest welcome to our international and national speakers, delegates who have traveled from abroad and across Pakistan to join this forum of knowledge, exchange, and collaboration. Your expertise and experiences are invaluable contributions to our collective learning. The conference theme, Nuclear Medicine, Expand and Boundaries. I extend my warmest welcome to our international and national speakers, delegates who have traveled from abroad and across Pakistan to join this forum of knowledge, exchange, and collaboration. Your expertise and experiences are invaluable contributions to our collective learning. The conference theme, Nuclear Medicine, Expand and Boundaries.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. بسم الله الرحمن الرحيم. اقرأ باسم ربك الذي خلق. خلق الإنسان من علق. اقرأ وربك الأكرم الذي علم بالقلم. علم الإنسان ما لم يعلم. صدق الله العظيم.
Ladies and gentlemen, please rise for the national anthem. Esteemed members of Pakistan Society of Nuclear Medicine, respected colleagues, ladies and gentlemen, Assalamu alaikum and a very warm welcome. On behalf of the President and the Executive Council of the Pakistan Society of Nuclear Medicine, it is both an honor and a privilege to welcome you to the 10th annual conference of our society. Your presence here today is a testament to the growing strength, unity, and vision of the nuclear medicine community in Pakistan. This year's conference is held under the theme Nuclear Medicine in Pakistan from Gamma to Beta and Beyond. This title reflects not only the evolution of our field from foundational gamma imaging to advanced beta and targeted alpha therapies, but also our collective aspiration to push boundaries, embrace innovations, and shape the future of nuclear medicine in Pakistan. Following this, I invite Dr. Mehdi Raza Tamghai Basalat, President of the Pakistan Society of Nuclear Medicine, to deliver welcome address.
Assalamu alaikum and a very good afternoon, ladies and gentlemen. There is a little change in plan due to some unforeseen commitments of the chief guest. He is late and has asked us to start the proceedings of the plenary session. Once he comes in, I will deliver my formal welcome address and we will proceed with the inauguration. But till that time, we will start with the plenary session as per our schedule, and we may interrupt the plenary session for a short while we seat him on the stage. Then I think it will be probably between two lectures so that the lectures are also not interrupted. Then we will start with my address, his address, and we'll proceed with the rest of the talks of the plenary session. I'm sorry for the inconvenience, but this is something which was beyond the organizers, so we have to bear with it. I'm so grateful for your cooperation and your presence here this afternoon and the active participation that we have witnessed in the pre-conference workshops, and we hope that the same spirit continues throughout the main sessions of the conference. We have guests from abroad and from different parts of Pakistan, and you would know many of them and would learn to know many others. They are all eminent people, renowned professionals, known figures nationally and internationally, and we will try to learn from them and to develop our rapport with them for future exploitation of the good that they can bring to us and to our careers and our learning. I thank you very much for your patience, and may I request Dr. Saima Muzahir, who will be the moderator for the plenary session. She's also the Vice President of the Pakistan Society of Nuclear Medicine and is based in Atlanta, Georgia at the Emory University in the United States of America, to take over and start with the plenary session. Thanks a lot.
Thank you, Dr. Mehdi. Distinguished guests, respected faculty, colleagues and friends, Assalamu alaikum and a very good afternoon. It gives me immense pleasure to welcome you to this plenary session of the 10th Annual Conference of the Pakistan Society of Nuclear Medicine, being held under the inspiring theme, Nuclear Medicine in Pakistan, from Gamma to Beta and Beyond. This session brings together 4 distinguished international experts who are stalwarts in the field and have contributed immensely in advancing the science and practice of nuclear medicine and cardiac imaging worldwide. The keynote talks will be followed by the panel discussion and an opportunity for audience interaction as well. So without further ado, let's begin our first plenary speaker. It is my absolute pleasure to welcome Professor John Bascom, who recently retired as a specialist in the nuclear medicine from Cambridge University Hospitals. He has over 30 years of experience in nuclear medicine, published over 250 scientific papers with over 9,000 citations, and has authored and edited 8 books. Professor Bascom has been involved in medical education, being a module lead for the UK Nuclear Medicine MSc and examining for the FEBNM, PIAS, and the Hong Kong College of Radiology. Professor Bascom.
Thank you very much. Thank you for the invitation to come, and particularly I want to highlight the students who came this morning for the examination, and thank you all for your contributions and for your dedication to being the future of nuclear medicine here in Pakistan. I'm not going to talk about something that's too complicated, and it's the kind of test which many centres will be able to do with simple techniques. So I'm going to talk a little bit about SPECT-CT in pulmonary embolism. I don't have any disclosures. I'm too old for anybody to take any notice of me. It's wonderful. So we're going to look at just what we tend to use for the investigation of pulmonary embolism and how that has evolved from planar towards SPECT-CT, and just a couple of little slides on some new areas that are opening up in SPECT-CT pulmonary perfusion imaging. So, to many of us, VQ lung scanning is a standard technique. It's something we know more about, and we use two agents to do ventilation and perfusion. The perfusion we normally, university now use technetium MAA, but ventilation agents differ. So some places are very rich and they can afford krypton gas. I haven't put xenon down, I'm so sorry. I'm not realizing quite so many people from North America here, but a gas such as krypton. But most people are using some form of either aerosol or a smoke-based system with Technogas. So I did mention xenon, but because evidently it has safety issues, we're not allowed it in Europe. Now, new work with SPECT and SPECT-CT might alter the choice that we would have of those agents that are available, because what we need for a SPECT study is a good count rate and a good stability. We don't want the agent moving during a 20-minute acquisition, for example. Let's start off with krypton. Now, I suspect, unfortunately, many of you may not have had experience with krypton 81M. You get it from a rubidium generator. It has quite a high energy gamma ray, which means that you can do simultaneous acquisition with the technetium. But what you need to do, of course, is you need to continuously supply it. So effectively, you strap the patient to the generator and you pump through either air or oxygen so that the patient will breathe that in. The radiation protection is very simple, because by the time the patient breathes it out, with the 18-second half-life, it's all disappeared. And it's very good with SPECT. I'm just going to show you some planar images first. This is actually with krypton, and you can see very nicely, you get a nice image. So the top set of each row is the perfusion, the bottom set of each row is the ventilation, and you can see these are nicely matched. You get nice, crisp and clear imaging. What other agents? So most people, if they're going to do ventilation, will be looking at trying to do something that's like an aerosol. Now, they're cheap and easy to use, but the finer the particle that you use, the better the penetration into the small peripheral airways, and also you tend to get better stability because it stays there for a little bit longer. Because what happens is with these aerosols, that they normally are moved back into the central airways and then brought up and swallowed by what we call mucociliary clearance. In fact, some people use that as a test of mucociliary clearance. But the residency for most of these aerosols is long enough to be able to do SPECT, even though it's not as stable as you would wish. So how do we do it? Well, it's basically a variation on the nebulizer that many people may have used or given to their kids for asthma when they have salbutamol. You basically have air that is twisted through a fluid, and it produces a fine aerosol, a bit like a mist, which the patient breathes in. Now, there are some complications because what you're breathing in is radioactive, so there needs to be some additional stuff around in terms of shielding and trying to make sure that the mask fits closely to the patient so they don't spew radioactive DTPA all over the room, and more importantly, the gamma camera in some ways. There is some issue that in patients who are, for example, smokers or people who've got airways disease, you can get clumping in the major airways. But the residency tends to be about 20-25 minutes, which is long enough to get a reasonable SPECT study. The only problem is, of course, that we tend to have to do that before the perfusion, because we need to get that to clear before we can give the MAA. So you then end up doing a ventilation on every patient. So radioactive smoke was invented in the 1980s in Australia, and it uses a DTPA, and what it is heated very, very quickly in a platinum crucible to a very high temperature, about 1300 degrees centigrade in a flash heat. And this produces something called a C60, that's a carbon-60 buckyball, and that contains the actual technetium. And these buckyballs are very small, and they can be breathed in very well. And they again use a sealed system, so you don't get the stuff to spew and escape everywhere. So the technique is fairly simple. You put some DTPA in the platinum crucible. You then heat it very, very quickly. It produces a very stable smoke, which you can then give to the patient. And these bucketball smoke, they stay in the lungs. Some of them are breathed out, but some of them are cleared by, again, mucociliary clearance. The clearance is a little faster than it is with the aerosols because it's not so dense. So you can often do the perfusion imaging about 15 minutes after the ventilation instead of waiting an hour or two. Now, if we do some imaging, this is some imaging done with Technogas. It looks just like the Krypton. And again, the upper one is the perfusion and the lower one is the ventilation. You see, I'm still in examination mode here. And you can see there are multiple defects in perfusion with normal ventilation. And I think all of us will be confident in saying that will be consistent with multiple pulmonary embolism. I don't think anybody in this room would have any difficulty saying that. However, sometimes it's not so easy. Here we have a defect in perfusion. It looks like it's the size of a segment. So could that be a segmental pulmonary embolism? But when we do the ventilation, we can see the ventilation defect is larger than the perfusion. So this is probably a parenchymal lung problem. Most likely in somebody that's fairly young, this may well be an acute viral chest infection, for example. So this one, subtle changes, but again, I'm sure that if I had this in the examination tomorrow, most of the trainees would be able to say that this is not a pulmonary embolism. So we always do some constant reviews. So these are some reviews that we did at the Royal Free Hospital. I think Dr. Akhtar helped with this, didn't you? Yes, you did. I found this slide, and you helped do this audit for us. So we looked at around about 300 patients who had planar VQ lung imaging, and we found that our equivocal rate was around 12%. So those 12% went on to have CTPA along with some of the patients that they decided to do CTPA on. But you can see that what you've managed to do by having a good and consistent service is that 2/3 of the patients did not need to have CTPA. They could be managed perfectly well in nuclear medicine by VQ lung scanning. But the question is, could we get that equivocal rate down further? And we'd really reached the limit of what we could achieve with planar imaging. So SPECT VQ became the next thing, and this was all developed by Professor Balic, who works in Sweden, and she did multiple studies published in the late 2000s, early 2010s, and she was able to reduce that equivocal rate from around 13% down to about 5%. And particularly she noticed a big improvement in sensitivity compared with CTPA. So if you look at some of the published data, particularly from things like the horrendous PIOPED studies in the US, they will say that PE only works in 60% of patients. If you do your test properly and use proper criteria for diagnosis, which is what Professor Balic did, you can get that up to 95%. But it is technically more difficult than planar. There will be a higher radiation dose of using Krypton because you need the patients to breathe in for longer. However, that radiation dose may not be much worse than CT. Now you can do it with aerosols, but you really do need to make sure that you clear the aerosol before you do the perfusion. So you may be talking 2 20-minute acquisition and a 1-hour gap between. So that means the patient will be in your department for just under 2 hours. And that's quite a considerable period of time taken to get a diagnosis. But for many places, they find this a very useful test. So this is from the paper that was presented in the guidelines in 2009. Now you may say, are there any newer guidelines? And the answer is no. So this is the most recent E&M guidelines on lung perfusion VQ. And here you can see these are not planar images, these are coronal slices. And you can see quite a small defect there, which is probably subsegmental, which you can see in the right lung, and they put a very nice arrow on for you. And when you look at the CTPA, there is indeed a subsegmental embolism. So we can start to pick up with more certainty much smaller pulmonary emboli. So for many places, this has now become the standard test in nuclear medicine for pulmonary embolism, and would expect most centres in patients who can tolerate lying down for 20 minutes or so to do a SPECT VQ and not a planar VQ. This is one of my patients, and here you can see this patient, the top line is the perfusion, the middle line is the ventilation, at the bottom is the two images merged, and you can very nicely and clearly see that in the left lung there's a nice big defect there, and on the right lung there's a subtle small defect, and there are defects in both lungs. So this again should produce a very good result in terms of establishing this patient has multiple segmental and subsegmental pulmonary emboli. So what about SPECT-CT for pulmonary embolism? Well, of course, we can potentially provide data not seen on a VQ lung scan. Particularly, we can look at lung abnormalities. Patients with no lung disease, such as COPD, which we would tend to try and avoid doing VQ lung scans on, maybe we can do those patients, because those patients we can see underlying abnormalities, so we don't have to produce a report that says there are multiple defects in ventilation or perfusion. This may be due to pulmonary embolism, but could be due to underlying COPD. If we know where the COPD is causing problems, then we wouldn't have to do that kind of report. Now, obviously, we do have a breast dose from CT, but we can use fairly low dose CT, and in younger women, for example, that doesn't need to deliver a higher breast radiation dose than doing a ventilation study either with a technetium aerosol or krypton gas. In fact, do we need a ventilation study? If we're going to be looking at the lung structure with the CT, maybe we can drop the ventilation and just have perfusion, and then we can have that with the CT. And that would make everything simpler and quicker. If you have a patient come in, you can give them MAA, you can do the SPECT-CT, and they're out in 25 minutes instead of nearly 2 hours. So suddenly you become more efficient as well. But before we go down that path, we need to know, is it better, is it the same? So there have been some studies published on this. This was Roach et al. A long time ago, 15 years ago. He tried to do a prospective study of looking whether or not SPECT-CT could replace SPECT-VQ. And again, he identified that there were advantages in looking at underlying lung disease. And don't worry, I'll show you an example in a minute. He also showed that he could overall reduce the radiation dose of the patient by not using the ventilation scan. He did note, however, that there was potential issues in image blurring, because clearly, while you're doing a longer acquisition, whilst we're doing the perfusion, the patient's lungs will be moving, whilst with the CT scan, even though you do a resting CT, there may be less movement, so you may get a bit of misregistration. That is less of an issue now, because most of us now have SPECT-CT with either 8 or 16 slice, as against the 2 slice they had at the time. Published paper from Poland 10 years ago, looked at 100 patients that they did prospectively, again looking at planar VQ, SPECT-VQ, and SPECT-CT perfusion only, and they compared that with CTPA and clinical outcome. And the numbers tell the story, don't they? If you look at the sensitivity and specificity, as you move towards perfusion SPECT-CT, you improve significantly both the sensitivity and specificity. Now, the specificity is not 100%, okay, but it's still pretty good. But the important thing is the sensitivity is to 100%. That means you're picking up all the pulmonary emboli, which is what we want to do. So what about CTPA? Because somebody will say, well, radiologists still do CTPA, I can't get any scans done. Well, this was a study done in 2016 of 100-odd patients that compared SPECT-CT with CTPA. And they noticed that the SPECT-CT sensitivity as against final diagnosis was about the same. So if somebody says to you, well, CTPA is better than nuclear medicine, the answer is actually no, it's not. It's the same. Another paper published more recently from Italy, they did a review of 8 studies comparing perfusion SPECT-CT and CTPA. And they came to the answer that the SPECT-CT sensitivity compared to CTPA was 96% and specificity 95%. And statistically, that is no different from 100 to 100. So there is clear evidence that SPECT perfusion CT, if done correctly and you learn how to do it properly, is as good as CTPA. So these patients no longer need to go toddling off to radiology. They can now all be managed in nuclear medicine. Now, whilst all this data was coming out, something else happened in the world, and that was COVID. So one of the problems with COVID is that we were all told to avoid aerosols, correct? Don't do aerosol things. And of course, the ventilation image for many people is an aerosol image. So there was a lot of discussion. I remember there's some discussion between the Americans and the SNMI and the ENM and the BNMS about how do we get over that. And in the end, in the BNMS, we looked at all the data and we said, if you can do perfusion SPECT CT, please do that. Only do the ventilation if you really need to do a ventilation study. And then you have to best dress up in your bunny suits and put on your special air handling hoods, and you have to completely dress up in these sort of bizarre things you had to wear during COVID. Now, there were some small studies that were done that again confirmed that by doing that approach, that you could actually ensure you had 100% accuracy. And this was a paper from Malaysia, so this could be done anywhere in the world. It didn't have to be done in America or in Europe, showing that we could, once we learned the technique, stick to SPECT CT with perfusion. So this is the kind of image that you can see. I'm just showing you just the perfusion and the registered image and here. And what you can see is that the registration is not perfect, but it's not bad. And one of the reasons is that you can ask the patient just to quiet breathe whilst you're doing the CT scan. But you can see here very nicely the advantages. You can look at the perfusion image, see where there appears to be a defect, and if you'll notice there's a little defect in the left lung, and then you can see if there's anything in the underlying CT scan. Now, not on this one because I'm just showing you the registered image, but when we start to use these images in reality, and this is a patient from Cambridge from just a few weeks ago, and here you are, you have a 25-year-old male, 3 episodes of pain and shortness of breath, no family history, no other history of anything else, just literally came into the emergency department feeling short of breath. And that was for 24 hours. And here you can see there is a slight misregistration, but it doesn't matter because clearly there are perfusion defects. You see the red arrows showing that basically within the lower lobe of the left lung there are segmental defects. And if you look at the CT very carefully, you'll notice the CT looks quite black there. And that's because there's no lung markings, because there's no perfusion of the vessels. Okay? So the vessels have collapsed because of the pulmonary embolism. But you also notice there's no other lung disease. So the explanation now, you can say, is that there are defects in perfusion at segmental size with no underlying CT to explain that perfusion defect, such as a tumor or infection. Therefore, this is pulmonary emboli. So you've gone from 13% equivocals to being able to deliver 0% equivocals. On other times, you have patients which are difficult. So this is a 70-year-old patient, female patient with a history of pulmonary hypertension. And one of the causes of pulmonary hypertension are chronic repeat pulmonary emboli. Now, this patient had a CTPA that was negative, but they weren't happy and they wanted to know were there peripheral perfusion defects. So we did a perfusion SPECT CT. You can see, in fact, if you look at the orange color, that the perfusion is pretty homogeneous. It's a little bit bobbly, but it's not too bad. But there are no focal defects, okay? But when you look at the CT scan, this is on lung windows, you can clearly see there is fibrosis in both lungs. So again, in a difficult patient, this gets you out of trouble because you can say, though it's non-homogeneous, there are no segmental defects, therefore it's unlikely that this patient has had pulmonary emboli. However, the reason the patient is breathless is because of the fibrosis, diffuse fibrosis throughout both lungs. So you can get diagnostic answers very quickly. So the use of the SPECT CT just with perfusion, no ventilation, has enabled us to ensure the correct management of this patient. So studies are starting to work on this. There's a prospective study here that's going ahead in France, a multi-center trial. And what they'll be doing is looking at perfusion SPECT-CT to answer that question. When a patient has had a pulmonary embolism, they've been on anticoagulants, when can you stop the anticoagulants? Normally we stop at 6 months. Some patients may need it longer, so they're going to do a prospective trial to see whether or not we can use perfusion SPECT-CT to see if there is any residual perfusion defect at 6 months, and from that determine whether the patient can stop their anticoagulants or need to continue and have a further SPECT-CT 6 months later. We don't know the results yet, that's due in 2028, but it clearly shows that the confidence that the clinicians have in the study to ensure that they can now do a funded prospective trial. They wouldn't do that if they weren't confident in the results delivered with perfusion SPECT-CT. Now, you get a free CT. Now, I know you guys might not want to look at the CTs. Now, I know you guys actually can look at the CTs, but you often need to get a radiologist just to confirm things. But the one thing that we always worry about CT, are we missing any significant pathology? Particularly, are we missing a small lung cancer? And looking at these things can be quite complicated. However, this is where AI comes in. Now, we live in, most of your younger people, you live in an AI generation, don't you? If you want to know where to eat tonight, you'll go to your phone and you'll say, where's the best tower? Lamb mutton tower. I want mutton tower. Where's the best mutton tower near this hotel? And the AI will work it out and say, if you go to this restaurant that's 3 streets away, this has the best mutton tower you'll ever eat in Lahore. We use AI every day, even without knowing it. So using AI on the CT scan is a very fast bit of work that's done. So they've taught the CT scan, they taught the computer to read them with patients with lung cancers, patients without. And this was published recently in Radiology. It did show, however, that it did overcall. So you still need a human to look at the scan after because the AI, what it does, it picks up 3 or 4 lesions and it says to you, are these significant? And if they are, you then report that. So watch how AI is coming to nuclear medicine as well. So in summary, SPECT-VQ and SPECT-CT perfusion are both good methods and if done well deliver very good results. Ventilation agents can be problematic. If you're doing perfusion SPECT-VQ with SPECT-CT, don't need to worry about it. And it's as good as doing a SPECT-VQ scan, and it's as good as doing a CTPA. So new ideas, how can we use this technique now in monitoring patients, and the use of AI to help us read the CT scan. Thank you very much.
Thank you very much, Professor Bascom, for a very comprehensive talk on PE and VQ imaging. It is now my absolute pleasure to introduce Professor Dr. Hussain Jadwar. Professor Jadwar is Professor of Radiology at Keck School of Medicine, University of Southern California, with joint appointments in radiation oncology, urology, and biomedical engineering. He is past president of both the ACNM and the Society of Nuclear Medicine and Molecular Imaging, and also led the SNMMI Therapy Center of Excellence. His extensive academic background includes degrees in engineering, medicine, public health, business, and law from top institutions such as Michigan, Harvard, and USC. Dr. Jadwar has authored over 260 peer-reviewed papers, 4 books, and holds several patents with notable contribution in PET imaging, theranostics, and prostate cancer. He serves on the editorial boards of major journals and chairs the US NRC Advisory Committee on Medical Use of Isotopes. Thank you, Dr. Jadwar.
Thank you very much, Saima, for that very kind introduction. It's a pleasure to be here in Lahore, Pakistan. It's my first time. And I want to thank Drs. Muzahir, Raza, and Inamullah, I hope I said that correctly, for their generous hospitality since I've been here. So what I'm going to do today is talk about lutetium PSMA and some of the challenges that we have been facing as we started using this agent. These are my disclosures, but none are relevant to my talk today. So this is the outline. I'm going to talk about the patient eligibility, especially focusing on imaging, and then talking about treatment dosing and scheduling. How do we decide about delaying, sometimes perhaps reducing or restarting, retreatment? How do we make actually those decisions as we go along and take care of the patients? And also, how do we deal with patients who have renal impairment of some sort and patients who have diffuse marrow disease? So let's just start with the first one, patient eligibility. Again, we're talking about imaging in here. If you look at the major clinical trials that have been done so far, the LuPSMA therapy trial and the VISION trial, they all use different eligibility criteria. The LuPSMA and therapy trials from Australia, they actually use the semi-quantitative numbers with regard to SUV max of how to decide if a lesion is PSMA expressing. They also used FDG, and they compared the FDG and PSMA PET and excluded patients who had FDG positive disease and PSMA negative disease. With those trials, LuPSMA excluded about 16% of the patients from the trial. The therapy was really about a third of the patients were excluded based on the rather extensive criteria that they used. But in the VISION trial, they tried to be very simple. So basically, they did not incorporate FDG at all, and they basically used the visual determination of if a lesion is positive or not. No semi-quantitative analysis. They also used the CT to decide if a lesion is large with regard to RECIST 1.1 criteria, but is not expressing PSMA. So those patients were excluded. Using that criteria, you see that they excluded about 13% of the patients from the trial. 5% of them were based on no expression on PSMA PET, and about 8% based on diagnostic CT. Now, this picture has probably been shown thousands of times at different conferences. This is from the Mike Hoffman group at Peter Mac in Australia. And as you can see, they basically divided the patients into patients who may be unsuitable for receiving the treatment and those who are suitable. The suitable are the ones that have no FDG positive disease, lots of PSMA expressing lesions, or they can have FDG positive disease, but it has to be concordant with the PSMA PET. If there is discordance, if there is no PSMA positivity, then of course those patients should not be eligible for PSMA type radioligand therapy. Also notice that as time goes on and a patient are being treated with lutetium PSMA, things can change. So that you may get new lesions, there may be new discordance that develops. This study was actually quite interesting. This was from Germany. They used their own imaging criteria, which also incorporated FDG, but they said, okay, let's look back at the patients that we already have treated and apply the VISION criteria, which was very simple, and see if we missed anybody. And when they did that, it turned out that 7% of the patients would have been treated if they were using VISION criteria, but they were not treated based on their own criteria. And 4% of the patients were treated based on their criteria, but would have been excluded if they were applying the VISION criteria. But the final conclusion here was that actually it's a minority of the patients that would be excluded from treatment if they just use the very simple VISION criteria, which does not use FDG at all. This is an example of this. The top is a patient who was considered VISION eligible. There are obviously you can, I don't know if I can use here it is. You can see there are some lesions up here which are PSMA expressing. However, if they had the FDG information, you see there are a lot of more lesions that are FDG positive, not PSMA expressing. This patient would have been VISION eligible, but based on their criteria, which also incorporated FDG, this patient did not receive the treatment, but that was the right thing, should have not received the treatment. And then the bottom one is the patient who would be VISION ineligible, and based on their combined FDG PSMA PET was also ineligible due to large lesions with soft tissue component in the bone and also liver lesions. So I published an editorial in JNM a few years ago, basically summarizing how we can think about this. So especially initially patients who have a lot of PSMA expression, these patients should really be treated with lutetium PSMA. But as time goes on, the tumor becomes a lot more aggressive, and then you get into the situation that there will be a lot of FDG positivity, very little or no PSMA expression. Those patients really, the radiopharmaceutical therapy should not be considered as the main stay for treatment, although there are thinking about perhaps we can use some agents like androgen deprivation therapy to prime the disease, in other words, make the tumor to express PSMA, and perhaps that can be used as a way. And then of course there's a lot of patients in the middle in here, and those patients we can think about how is it possible to intensify the treatment, give higher doses, or use combination therapy. Moving on to treatment dose and the schedule modification. Now, if you look at the package insert for Pluvicto, you see this is the basically what they recommend. Every 6 weeks you give 200 millicurie, and if there is toxicity, there's an issue that you have to bring the dose down, you can bring it down by 20% to 160, but you cannot increase it anymore. You just kind of stay at 160. But you have to remember that with lutetium PSMA, complete response is quite rare. We have a very, very few patients who have maybe 10% or so who will have an exceptional response, and sometimes visually complete response. But there's a lot of stable disease and partial responses, and none of these are durable. Eventually the patient will progress. So the question is, again, how do we decide, is it possible to give a patient a holiday? Just like the chemotherapy. Chemotherapy, in medical oncologists will always give patient holiday if the things are going the right way. And if the patient is progressing, is it possible to intensify the treatment? And how do you decide on combination treatment? There are some papers out there that was published in JNM and EJ and MMI. I invite you to look at those that discusses some of these issues. So this is an example of a patient with exceptional response. You can see the PSA was over 1,000, very kind of a very diffuse marrow disease in this patient, PSMA expressing, received 4 cycles of Lu-PSMA. The PSA went down to less than 1, and the scan looked really, really good. So should we still treat this patient, or can we give him a holiday? That's the question. This is the same kind of a study that was published by my friend Amir Iravani, who's at University of Washington now. So again, a patient with a lot of disease received 3 cycles, did quite well, PSA went down, and then they didn't do any treatments for 6 months. Patient was still doing good. Even the PSA went down further. So they just gave him a holiday. But again, as I mentioned before, these patients always progress. Now, PSA went up at 9 months, and they said, okay, now we can start the treatment again. So now you're trying to prolong the time, you're buying time for the patient. You just don't go at a certain time. What about the issue of a SPECT-CT? So this is a paper that basically looked at that from UCSF, University of California, San Francisco, and they looked at and they found out that if you do a SPECT-CT just at 24 hours after every cycle, you can try to look at the images and make a decision if the patient should continue with the treatment or you can give him a holiday. And it turned out that 50% of the patients' management were changed when they looked at this SPECT-CT. And also, it turned out in some cases, and it's quite actually common, that you see in patients that have imaging progression, but the PSA is actually going down. So what is going on there? There's a discordance in here. This may be due to the fact that you're getting some of the old lesions responding, so the PSA is doing a good job, but at the same time, you're getting new lesions that are developing elsewhere that you didn't have before. And also you may have new disease that may not be even PSMA expressing, and they don't even produce PSAs. That's why the PSA is not going up. So very complicated. So again, if I want to summarize for modulation of treatment, remember the PSA imaging and clinical profile, they can all be discordant. They don't have to go hand in hand. So that's where the art and science of medicine comes. But you always have to give every patient 2 cycles, always. Everybody deserves 2 cycles of lutetium PSMA. You can continue the treatment if the PSA is going up, obviously there's not much radiographic progression. If there is hematologic toxicity, you can try to stop the treatment or reduce the dose, try to support the patient just like medical oncologist does with the chemotherapy, and then start the treatment. But if you see the PSA is going up and definition is more than 25%, imaging is not doing good, everything going in the wrong direction, patient is having some clinical decline, then at that point you may want to consider just discontinuing and going to a different treatment, especially if the patient has new liver lesions, the kidney is not doing good, and then the GFR is going down, or the patient has an unacceptable xerostomia. Now, the push is for biomarker-guided therapy. I talked about SPECT-CT, that's one way of making decision, but also you can do liquid biopsy, and these are some nice papers on that topic. What about liquid biopsy? This is a nice study showing that, these are two patients, one non-responder, one responder. If they did liquid biopsy, they took the circulating tumor cells and they looked at the PSMA expression on these circulating tumor cells. If there was the 10% of these tumor cells did not express PSMA, these patients did quite well. That means a lot of these tumor cells were expressing PSMA. However, in a non-responder, 50% of these circulating tumor cells were not expressing the PSMA. Therefore, these patients did not do very well. So you can use those circulating tumor cells to make some decisions for you. You can also look at what's called the copy number variations. This is basically the genetic material, the mutations that develops as the patient goes through the treatment. And it turns out that as you give the cycles of treatment to these patients, these variations increase in time, and the patients become progressive and they're not going to respond. What about retreatment? There is some data on that. This is the most recent one that has been published from Germany, and it turns out that they did a continuous treatment every cycle. They just gave every 6 weeks, they gave the treatment. In some patients, they delayed the treatment or gave the patient holiday, and then when the things kind of went up, they started the treatment again. And it turned out that they could really treat these patients for multiple cycles, all the way up to, I think in this case, up to 13 cycles. And they bought a lot of time for the patient in the re-challenge setting, up to 7 months. So it is feasible to do that. But you have to remember that as you do that, you have to look at the kidneys. We can see this study just presented at the ESMO in France, that you can see as time goes on with the first, second, and third challenge, your GFR is going down. So there may be some renal toxicity that you have to look into. Also, as the imaging-based evaluation, clinical evaluation, and PSA evaluation, when you go to the second re-challenge, you see that there is more progression going on. So disease is becoming more aggressive again as time goes on. The grand number of the cycles that one patient has received has been 20 cycles. This is actually from Australia. This patient, as you can see, his PSA level, he was challenged up to 20 cycles, but eventually, unfortunately, as we all know, he progressed. I think he was a patient who participated in the therapy trial. So what are the predictors of extent of response or resistance to radiopharmaceutical therapy? This is a complex situation. PSMA PET expression is not the only answer. You need that, but it's not sufficient. There are many other things going on. The volume of disease is important. You have high volume, low volume. The extent of tumor expression is important. Is it heterogeneous? Is it homogeneous? What kind of treatments the patient received in the past? What type of tumor microenvironment we're talking about? What kind of genetic variations do we have? So these have all kind of contributing to this complex nature. I have 2 more things to talk about. Renal impairment. In the VISION trial, the grade 3-4 renal impairment was only seen in very few patients, about 3%, but they had a very short-term follow-up, only 1 month. It turns out this is quite much of an interest to see if you're able to treat these patients with radiopharmaceutical therapy, if they have impaired kidney, single kidney, hemodialysis type. We are actually working on that right now with SNM. guidelines, so hopefully that will come out within the next year. But this study showed that if a patient has single functioning kidney, they can undergo these treatments with no problems. This is a patient with hemodialysis. In this particular case, they brought down the dose by 60%, and they treated the patient. The patient did well as far as cancer goes, but it turned out even with that, there was still a lot of bone marrow toxicity. This is another case that was published with regard to hemodialysis and how to deal with the radiation safety issues in these patients. But again, they concluded that if a patient is on hemodialysis, that does not necessarily mean that you should not treat the patient. You just have to be careful. Another paper showed that there may be long-term toxicity, but this paper from Germany, actually there was an editorial on that by Mike Hoffman. The point was here that a lot of this data that they presented, they really didn't account for the confounding factors. Some of these patients already had chronic kidney disease, so we really don't know exactly what the long-term issue is with renal toxicity. This last paper just got published with regard to kidney dose. Again, just like what I said with how to approach the patient with treatment, this is not a simple problem. There have been patients who have received a lot more grays of radiation to their kidney, even beyond 28 gray, which is the limit for radiation oncology, they still did okay. So, and that makes sense because the dose to the kidney is not as homogeneous as when you do with radiation oncology. Again, we need to really understand that issue better. So this is the basically summary of how to approach this. If the patient has a less than 30 milliliters per minute of GFR or is on hemodialysis, discuss it in the tumor board to see what you're going to do and how to approach this patient. If a patient has some reduction in the GFR but it's not in the failure mode, don't decrease the dose. Give the patient the benefit of the entire dose for the radiopharmaceutical therapy so that they can get their cancer treated. But remember, if the kidney is not doing very well, there's going to be a lot of activity around, and that may cause the bone marrow to get toxic. So you have to look at the bone marrow very, very carefully. This is the recommendation that was published in JNM that keep patients with greater than 30 milliliter per minute for eGFR and also some of the blood thresholds. And finally, on diffuse marrow disease, the VISION trial did not include super scans. They excluded those patients because they didn't know how to deal with it. So they said they kept it simple. But it turns out that actually patients with diffuse marrow disease can be treated. The problem is when bone marrow toxicity occurs, you don't know, is it really because of the treatment I'm giving that the patient is getting marrow toxicity, or is the cancer is getting worse? The marrow is becoming worse with cancer. So that's a difficult kind of a situation, and that needs to be also studied. But at this time, the recommendation is that if the patient have diffuse marrow disease, go ahead and treat these patients. They have no other options. So you should always give the patients the benefit of the doubt. Finally, there are a lot more issues that we need to talk about. I don't have much time on this, but we can talk about dosimetry. Is it really necessary, or is it a luxury if you have it? The role of the tumor microenvironment, genetic variations, and all that is really unclear at this point. Perhaps AI can help and bring all these multidimensional data together for us to make a better decisions. And of course, we still need to know what is the best combination and sequential therapies that incorporates RPT. I have two editorials that I published in JNM, which basically discuss all these thoughts that I just talked about in my presentation, if you're interested. And again, my last slide is, this is the goal for all of us. Add years to life and life to years. That is our motto for the rest of our lives, right? And with that, I acknowledge my funding from the NIH and other places, and I leave you with a beautiful picture of University of Southern California in Los Angeles, and as we say over there, fight on.
Thank you very much, Dr. Jadwar. Excellent talk. Always a pleasure listening to your talks. Now it is my pleasure to invite and introduce Dr. Humayun Bashir, who is a nuclear medicine physician with over 25 years of clinical experience in Pakistan, UK, and Saudi Arabia. He's a fellow of the College of Physicians and Surgeons, Pakistan, Royal College of Physicians, Edinburgh, and the European Board of Nuclear Medicine. He is a past diplomat of the American Board of Nuclear Cardiology. Dr. Humayun currently serves as consultant in nuclear medicine at East Kent University Hospitals, NHS Foundation Trust, UK, and an honorary faculty at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, Pakistan. He's been the past president of the Pakistan Society of Nuclear Medicine and is also a board member of AOFNMB, UK delegate to EBNM UEMS, and serves on the editorial boards of international journals and committees for BNMS and ACNM. Dr. Bashir has authored over 65 publications and received 400 plus citations and co-founded the Bashir Alawi and Yunus Bashir Awards to promote research in Pakistan. Dr. Bashir.
Thank you very much, Dr. Mehdi, for the invitation, Dr. Saima, for this brilliant introduction. It's quite a thing to be speaking after Professors Bascom and Jadwar. I hope I'll be able to present something exciting for everybody. Well, we live in a very sort of changing world, and we are looking for new and interesting applications for our conventional gamma camera. And one of these is scintigraphic imaging of joint prosthesis. No conflicts of interest to declare. It's a growing challenge. We have got more and more prostheses being placed all over the world, knee, hip, all the joints actually, shoulder and ankle as well. And we have an aging population. There are risk factors affecting the joints, but with that, there are advances in surgical techniques. The prostheses have improved and they stay there for longer, and more and younger people are getting it. And along with that comes with the risk of complications. More and more people are tolerating it, but those who cannot, they actually end up having problems which need to be addressed. So this is a bibliometric analysis recently published from a large team, which actually published from US, which actually shows, they look at the papers published focusing on prosthesis and its complications. And as you can see here, so the largest number has been published from US, followed by China, and this represents actually each country which has got more than 5 publications. And you see that over the years, the number of publications about complications of prosthesis is increasing. So just as we have more prostheses, more complications, and patients in need of analysis and imaging and all help to actually sort their problems. This is a document from the British Orthopedic Association, which talks about the surgical causes which can be cause of pain. So I've taken the example of knee prosthesis, while we can have these with all other prostheses as well, but knee is probably one of the major areas. So they have this acronym specific which talks about potential complications with soft tissue problems, patellar issue, extensor mechanism, component loosening, infection, fracture, instability, and component wear and tear. And in this guideline, this actually gives a comprehensive plan how every busy service should have a multidisciplinary team to look into the problem of pain due to knee prosthesis. And this mentions that SPECT-CT have an additional role. It can rule out, of course, a negative scan rules out many things. I'll just take a break. Okay. Yeah. Well, I'll briefly welcome Professor Gondal, President CPSP. It's quite a privilege because in 2017, I was chairing the PSLM conference in Pearl Continental, and Professor Gondal was chief guest over there as well. So time flies, we are back in the same position, right? So I'll continue with talk. Okay, so in this guideline which talks about how a orthopedic team should have a multidisciplinary setup where the patients with pain in their knees and along the process have to be evaluated, and this guideline mentions the role of SPECT-CT. This is a comprehensive review published in the Seminars of Nuclear Medicine, and in this busy table you can see at top there's aseptic loosening of the TKA component. That's the main indication, this one, for which we do SPECT-CTs. Then there can be less frequent indications of malalignment in which SPECT-CT has a role. Other instability issues are not where SPECT-CT can help. If hemarthrosis, of course, that's a clinical condition. In patellar maltracking, we are able to look at the bone turnover through the SPECT-CT. So there are specific applications where SPECT-CT has a role. As far as the structured approach is concerned, historically we used to have a 3-phase scan on with planar imaging, but now we are looking at, of course, initially we start with a review of the blood pool imaging, then we have to look at tracer uptake patterns on the SPECT-CT images, then we compare it with the CT and looking for lucencies, which is actually the structural change, and we assess all components, not just the bone, but the soft tissue and rest of the structures along the prosthesis, and then that's how we just have a comprehensive report. I'll talk through this flow. Blood pool imaging. Now we have got SPECT cameras, and most of the circuits like SPECT-CT. Initially, when we sort of started employing SPECT-CT for prosthesis, the early blood pool was still kept planar, but now even the early blood pool in which we want to look at the flow around the joint and soft tissues, the thing to do is to do a SPECT of that. In this first phase, we are basically looking at synovitis and effusion and all the soft tissue components. These are the planar images, and you can see in the early images there's slight halo around the left knee on the blood pool, like after the 1 minute it gets, it's more clear, more obvious, and SPECT-CT actually improves significantly on the planar images. So here you can see in these SPECT-CT images that you can see the hyperemia around or sort of encasing the prosthetic joint. So the protocol that we use at our center is that we do a SPECT of the blood pool, not the CT. At the later stage, when we do the delayed images, we do a SPECT-CT, and the CT acquired with the delayed images is then fused with the earlier blood pool SPECT. Some centers do SPECT-CT with both, but to save on radiation, we can do SPECT and then SPECT-CT and fuse the images. And as you practice it, our team are quite expert in fusing those images together. Now, once beyond the blood flow phase, we have to assess the bone turnover. And by the way, bone turnover, we use the word osteoblastic activity in our conventional bone scans, but here the term is actually bone turnover. Now, this is a nice table which actually tells, because when you're looking at joints, there'll be physiological uptake, and then it goes with the age of the prosthesis. And the patterns are different for different scans. Like here they have compared the total hip. You can have a normal uptake around up to 2 years. The knee area is more, it shows more changes to stress. So the normal uptake, which is heterogeneous in the components of the femoral and the tibial knee prosthesis, it can be normal up to 4.4 to 5 years. So it's important to know what's the age of the prosthesis. This is a normal biomechanical stress as seen along the femoral component of a hip joint prosthesis. You can see there's linear uptake, not very focal. Apart from once we have sorted the synovitis bit on the early blood pool images, next thing we are looking for loosening, which can be septic or aseptic. And it is basically caused by the mechanical movement of the prosthesis. There can be other factors. While either the placement was the initial positioning was not very accurate, and that leads to loosening, and there can be changes along the bone which were worse than what was expected. In each bone, there are pressure areas, like in tibia, it can be the tip, where the tip of the distal tip of the stem, and it can be along the tibial tray. In femoral, it's along the condyles, more importantly toward the posterior superior aspect. Patella is one area which is quite prone to changes due to the pressure effects in the acetabulum we go along the cup, and in the femoral hip there can be uptakes along the fulcrum area like the trochanters, and of course at the tip. So we have to look at these patterns. So the hallmark of loosening are component migration, which actually causes it. On the early blood flow, they can be increased. There will be hyperemia, for which there will be corresponding uptake later on. And then, of course, on CT images, the cutoff or the definition we look for is to have an osteolytic area which is more than 2 millimeters. This is a good paper in which they actually compared, or they actually elaborated what the usefulness of SPECT blood pool images. And in this case, in this first image A and B, you can see the blood pool along the femoral and tibial component is unremarkable, while on the delayed image you can see focal uptake along the lateral tibial plate, while in the other case there was hyperemia as well as increased uptake. So the first images A and B represent what potential loosening but not very worrisome, and the patient was treated conservatively because the blood pool was normal, and the delayed images showed bone turnover. In the second case, you can see there was focal blood pool with corresponding increased bone turnover, and that was called loosening, and during the revision it was confirmed. This case actually elaborates. Firstly, it says that SPECT is always better than planar imaging, SPECT pool and the delayed SPECT CT. Secondly, that once we, in imaging we suggest, it's a very complex process. It's not just the SPECT CT. There are clinical suspicion of loosening. Patient has got clinical complaint of pain. All those factors put together, then the patients will come for a SPECT CT. And in that, once we consider this is loosening, it's the revision process which will actually confirm when the surgeons go in whether it's proven loosening or not. And apart from the tracer uptake, the CT is quite important, which actually defines the lucencies. This is an example of the lucency along the lesser trochanter, while there's cement along the greater trochanter. So the pattern of uptake just around the bone, whereas the interface between the prosthesis of bone, that's very important, as CT is fundamental tool which we have as part of SPECT CT to look at this. Now, while we're looking at osteolysis, there are physiological things going on. Now, in this image, you can see that the greater trochanter is quite loosened. This is called stress shielding, and this happens because of the prosthesis. The weight bearing is shifted, and the weight is taken by the metal bit of the whole prosthesis, and the trochanter is not getting the same weight as it would have sort of experienced without the prosthesis. So there's loss of bone osteopenia there, and this is called stress shielding, and these are the kind of things we need to recognize when we are reporting these scans. In this patient, you can see that clearly the lower tip of the femoral prosthesis actually almost fractured the end ostium of the bone, and that's, you can see, increased uptake there. This is an example of an acetabular component. There's uptake around the acetabular cup, and there's an osteolysis, patchy osteolysis, which is more than 2 mm and corresponds with loosening. This is an example of a tibial component, and the medial tibial plateau, you can see focal uptake, and on the CT images, there's a nice area of osteolysis which is more than 2 mm. Patellofemoral denervation. We commonly get patients in which the clinical complaint is actually knee pain, the knee prosthesis pain, and the surgeons are suspecting that it's not the femoral or tibial component, but most problem is around just the patellofemoral joint. And this is quite common because this uptake you can see in the patella. This patient will be, surgeons will be providing sort of resurfacing of the patella to address this problem, while the tibial and the femoral components are quite normal. We also come to see unicompartmental prosthesis, which of course mostly is for the medial parts of the joint. And here again, we look at the femoral and the tibial component, and then there can be intercondylar impingement as well. So, these all patterns. It's more and more when you do these scans, you come to recognize these patterns around it. Soft tissue is another thing that you actually look at when we are looking at the prosthesis. This is a case of ischiofemoral impingement. So that's a friction is causing, and you can see the femoral component is eroded over here. this is a case of pseudoarthrosis because of heterotopic bone formation, and that was mostly, it's actually picked up on x-rays, but the patient would go for imaging when there's pain, and then they can see that while the components of the prosthesis was fine, but it was the ossification within the soft tissue and the muscles which actually has sort of developed and is causing pain. Now, this is a very interesting concept of aseptic lymphocyte-dominated vasculitis-associated lesion. They call it ALVAL, and this is basically a foreign body response to particular debris from the metal which has been used for prosthesis. And these actually things are, on imaging you can identify these, areas of which look like osteolytic. There can be, this is an area of, and there can be soft tissue pseudotumors as well, and these are identified in the imaging, but ultimately they are confirmed on surgical procedure when the surgeons go in. Then that retrospectively is considered ALVAL. There was no other evidence of any infection or sepsis, and these features actually are pointing towards ALVAL. So these are, complications beyond just loosening. Infection, of course, is a major thing. That's what we're looking for. But what happens is that in clinical practices, joint prostheses which are clearly infective, they are not the ones which actually come for SPECT CT imaging, because that's a clinically evident thing. It's basically the cases in gray areas when pain is there and nothing else is actually explaining it. This is just to give an example of a prosthetic infection. There's hyperemia on early phase, blood pool delayed, and of course there's periosteal reaction, thickening. In practice, you really do not come across such cases. These cases are clinically quite evident, and they're treated at the surgical level. These are, of course, if you're looking at infection, then there are features of increased uptake, and then there are very peculiar CT features. This is, when we are doing SPECT CT, there are very specific components which have to be assessed on CT. I'll just quickly go through, because these are basically for MSK radiologists to comment upon. Nuclear physicians, which are actually reporting, unless they're very well versed in all these numbers and calculating these things, they can talk about it, and there are dual certified people, we look at it. But of course, there are certain very specific angles which actually explain the positioning and problems of prosthesis, and there are specific patterns for each prosthetic joint. This is the image of a SPECT CT. We're looking at the tibial slope. And these are T-component rotation methods. Now, a few cases, I have time. This is a 71-year-old patient with a right knee pain, and this patient actually had a whole body scan because he also had a history of prostate cancer. So once they were doing a bone scan, we looked at if there were any metastases, but this is essentially a normal scan. I've just put here the blood pool images. They were unremarkable. SPECT CT was unremarkable. The patient did not have anything around the right knee prosthesis to explain the pain. This is another case, a 75-year-old. This is like a 6-year-old prosthesis. Patient had right knee prosthesis with pain, and here the main uptake is all around the patellofemoral joint. So that will be undergoing resurfacing, while the femoral and the tibial component of the prosthesis are unremarkable. Another patient, a 76-year-old male with history of a failing right TKR (infection versus aseptic loosening). Just to, we take this image from pelvis to the feet as a sort of standard planner part of the protocol, while mainly patients have a SPECT CT, SPECT blood pool of the knee, delayed SPECT CT of the knees. Then later on, we just take views from pelvis to see if there's any other problem outside the view of the joint, which is the main focus. So in this case, there was increased blood pool uptake, and on the SPECT CT early blood pool, you can see there's pooling around the entire tibial component as well as the lateral part of the femoral component, and on delayed images, you can see the entire tibial, medial, and the lateral plateau has got increased uptake. So this was a case of inflammatory loosening. Whether it is septic or not, they have to go back and look at the synovial fluid serology and others, infection, ECRP and ESR. That's where they can actually label it, actually grow microbacteria or something in the synovial fluid to confirm it. And as far as SPECT CT are concerned, we can actually say there's inflammatory loosening, and there was no osteolysis in this case. This is a second case in which you can see the focus along the medial tibial condyle. There was focal hyperemia. And on this delayed image, there was very refined osteolysis at this level. So this was loosening along with osteolysis. I just have got last two slides to show. This is the kind of key. This is the same paper from the seminars we use, in which they have given these patterns of bone turnover. So when you've got increased bone turnover along the femoral condyles, that will be indicating towards loosening. There's one uptake. If it's just the medial condyle of the tibia, then it can just be the varus deformity. So these are the pattern keys that you have to keep along when you are actually reporting these scans. These are the localization schemes which have been proposed. You can actually localize the areas, anterior or the posterior part of joint. They're different from the knees and different for hip joints. These are good to keep in view because this is the kind of terminology which the orthopods are familiar with. And this is the last slide. This is a sort of spec CT. They have done a meta-analysis. It's got a sensitivity of 94% and specificity of 84% for identifying loosening in the knee joints, actually both the knee and hip joints. So the take-home message is blood pool, SPECT is much better, is actually the one thing to do instead of planar imaging. It helps you comment about the synovitis. Then we have to know, once we are into the uptake phase, we have to look at different patterns. We have to compare it with the age of the prosthesis and with the CT findings of lucency to call it loosening. And we have to be aware of parallel phenomena like LVAL. Infection clues are given with the bone scan, but otherwise you have to have the blood picture, the synovial fluid picture, the microbial picture. In the MDT, I've recently started running it, and it's quite interesting. In the knee MDT, it's the orthopods, the microbiology people, the nurses, everybody is to be there. And what we have reported as uptake or bone turnover on our scans, it is put in the big jigsaw puzzle, and that's because patient has pain, and all these components are reviewed collectively to find out if there is loosening and if our imaging is able to identify the cause. That's about it. Thank you very much.
Thank you, Dr. Amayo. One of the topics which is always confusing, excellently presented. So we'll pause the last speaker for briefly, and Dr. Kashif will now introduce our distinguished guests here.
Thank you, Dr. Simon. It is a matter of great pride and honor for us to have Professor Khalid Masood Gondal, recipient of Tamga Imtiaz and Presidential Pride of Performance, President CPSP, as our chief guest today. It is a privilege to introduce Professor Gondal, a distinguished figure in Pakistan's medical education landscape. He is a graduate of King Edward Medical College and Fellow in Surgery, 1992. Professor Gondal has held numerous leadership roles, including Chairman of Surgery, Vice Chancellor of Fatima Jinnah Medical University, and President of the College of Physician and Surgeon Pakistan, a position he now holds for a second term. Professor Gondal has represented CPSP in global forums across America, Canada, the UK, Ireland, Saudi Arabia, and SAARC nations. He has been honored with the Tamga Imtiaz in year 2013 and Presidential Pride of Performance in year 2020 for his services in medical education. Now I again invite Dr. Mehdi Raza, Tamgai Basalat, and President of Pakistan Society of Nuclear Medicine to deliver the welcome address.
I'm here again. The first one was unplanned, this one is planned now. Bismillahir Rahmanir Rahim. Honorable Chief Guest, Professor Khalid Masood Gondal, Tamga Imtiaz, Pride of Performance, President, College of Physicians and Surgeons, Pakistan. Guests of honor, Major General Muhammad Amin Waqar, Hilal Imtiaz Military, Dr. Saida Asghar, and Dr. Khalid Nawaz. Respected conference faculty, experts, facilitators, delegates, ladies and gentlemen, Assalamu alaikum. It is a proud privilege to stand before you all today and welcome you on my own behalf and on behalf of the Executive Council of Pakistan Society of Nuclear Medicine to the inauguration of 10th Annual PSNM Conference in Lahore. As mentioned by Dr. Humayun, this reminds of our conference around 8 years ago in 2017 at the Pearl Continental Hotel, Lahore, where we had Professor Gondal as the chief guest. And now he is with us again today as President of the College of Physicians and Surgeons, Pakistan. Sir, thank you very much for gracing the occasion. This is a special year as the Pakistan Society of Nuclear Medicine has completed 30 years of its inception. And we are seeing the specialty of nuclear medicine and allied fields growing by leaps and bounds. We are lucky to have among us this afternoon Dr. Saida Asghar, the founding president of Pakistan Society of Nuclear Medicine and a senior nuclear medicine consultant who has been director of INMOL, the Institute of Nuclear Medicine and Oncology at Lahore, and was the initiator of this landmark event. For those of you who don't know the other two guests of honor, both are my teachers from my MSc days at PIAS, Pakistan Institute of Engineering and Applied Sciences, which were the early years of this millennium. The gentleman alongside the chief guest is Major General Muhammad Amin Waqar, Hilal Imtiaz Military, who served the cause of nuclear medicine in the armed forces from its early days when we worked with rectilinear scanners to the current days of hybrid systems. He has a PhD from London University. The nuclear medicine community from Lahore is, however, more familiar with the last gentleman sitting on my left side, Dr. Khalid Nawaz, another teacher of teachers, who is serving the city from after his arrival in Kuwait in the form of heading the department at Shaukat Khanum Memorial Hospital, the nuclear medicine department, and now developing and heading the nuclear medicine department at Pakistan Kidney and Liver Institute. Earlier this month, this is some recent news for you, being the president of the Pakistan Society of Nuclear Medicine, we have received a letter, an email from the European Association of Nuclear Medicine telling us that they have granted us affiliated society status. Next year, they will be inviting us to Vienna to the next ENM General Assembly meeting, and that will open doors of further collaboration between Pakistan Society of Nuclear Medicine and the nuclear medicine and allied community here with the peers in the rest of the world, especially European areas, the European region. We already have existing affiliations with the American College of Nuclear Medicine, the Korean Society of Nuclear Medicine, Asian Regional Cooperative Council for Nuclear Medicine, WOMT, which is the World Association for Radionuclide Therapy, and Asia-Oceania Foundation for Nuclear Medicine and Biology, the World Federation of Nuclear Medicine and Biology, the Chinese Society of Nuclear Medicine, and the Asian School of Nuclear Medicine. Around 30 nuclear physicians from Pakistan have already cleared the Asian Board exam, which is conducted by the Asian School of Nuclear Medicine. And this is being held annually since 2014. One of our Executive Council members sitting here, Dr. Kashif Rahim, he is the secretary of that exam board and is even now expected to visit Korea next month for the exam. I think I'd like to conclude for now on the note that nuclear medicine today has advanced from diagnosis to treatment. And the theme of our conference this year, Nuclear Medicine in Pakistan from Gamma to Beta and Beyond, is representative of this paradigm shift. These are the times of precision medicine and targeted therapy, and functional and molecular imaging in tandem with anatomical imaging. So we have to keep learning and evolving each day and keep helping our patients in synchrony with other healthcare providers in today's multidisciplinary environment. I'm so grateful for you all for being here this afternoon. God bless you all. Thank you so much.
Thank you, sir. I now invite our honorable chief guest, Professor Khalid Masood Gondal, to kindly share his thoughts and reflections with the nuclear medicine community.
Bismillahirrahmanirrahim. Nahmadu wa nusalli ala Rasulil Kareem. Thank you very much, Brigadier Badi Raza, for inviting me, and very happy to see the guest of honor, Major Amir Wakar, and the founder, director of Enmol, Dr. Saida Asghar, Dr. Khalid Nawaz, Professor Humayun, Dr. Humayun, who already invited me in 2017, Dr. Saima, Vice President, Dr. Kashif, Organizing Secretary, and I must congratulate you on completion of 3 decades of this society, and this is going to be your 10th annual event. The nuclear medicine is one of the important postgraduate program monitored by a College of Physicians in Pakistan, and CPSP, we know, the main postgraduate body of the country. In next 20 minutes, I'm just going to highlight about what is the college, what is the contribution of this college for this country and internationally, and with special reference to your own specialty. Now, college was, for the information of our international guests, I could see, I think international guests from various countries, they are there. This college is the main postgraduate body of the country, founded in 1962 by the Act of Parliament, and General Wajid Ali Barki, the founder of this college. The current council is elected by these fellows sitting in this hall. Depending upon the number of fellows, the distribution is 9 from Punjab, 2 from Armed Forces, then province of Sindh, 6 KPK, and Balochistan. The council is elected after every 4 years, and the office bearer every year. The mission of the college is excellence in the higher medical education through a structured training, monitoring, conduction of transparent examination system, and international liaison and scientific research too. We started from this building that's in front of you, 1962, and this journey going on, and credit goes to General Wajid Ali Barki, Professor Sultan Farooqi, Professor Zafrullah Chaudhary, and the successive council. Now, coming back to the field of medical education, quality and standard. Currently, the college has implemented competency-based medical education that started in 2008 in Canada with the name of CanMed, then ACGME competency of US, and the world faced the challenges, and so are the CPSP, the regional challenges. We face the challenges of induction, we streamlined that. Similarly, the phase of training, accreditation, curriculum, model of monitoring, supervision, and evaluation. We made various strategies to cope with all these challenges, and beside this council, we have got the 70+ faculty. The faculty of nuclear medicine is one of the important faculty of CPSP. The council regularly consult these faculties member, and we had the election on 18th March 2023. On 31st March, we consulted the faculties. What is the conclusion of our postgraduate medical education? How this is going on? What is the feedback? They said there are issues still with the standard and the quality, and we have to ensure the strengthening of standard and quality. And these faculties, they made these short-term goals and the long-term goal. Generally, you make them goals, but there is no time frame. But by the grace of Allah Almighty, we made the short-term goals, we made the time frame, and we achieved them. Work-based assessment, a new innovation in evaluation, the clinical examination, DOPS, they were implemented for all the faculties, for all the trainees, 2025 onward. Monitoring of the supervisor, we had 3,50,000 MCQs. All these, they have been revamped. including your own specialty. And then the feedback was that our examiner and the trainer, they are not having a continuous refresher courses and the workshop. Now the college has managed the refresher courses and workshop for all the examiner, for all the training, including the specialty of nuclear medicine. The curriculum, they have been revamped. Now we have started the re-accreditation of the institution and the supervisor who have completed 5 years, and then we are going towards the concept of re-accreditation, revalidation and recertification. This is the contribution of Department of Medical Education. The essential workshop for the trainee, these are the 6 workshops, and essential workshop of the supervisor, which include how you are going to teach, how you are going to evaluate, how you are going to supervise, and then advanced skill courses like ATLS, ACLS, PALS, also and PALS. And now we have included, along with the workplace-based assessment, the medical ethics in professionalism. In last 5 years, 1,19,000 trainees they were trained, and through these 4,000 workshops, and 22,000 supervisors in last 5 years. These are advanced skill courses, ATLS, ACLS, PALS, also basic life support. 79,000 trainees they were trained, and around 1,000 instructors they have been certified. Now this college is not taking a single penny from provincial or the federal government, and without any financial support, with the help of all these fellows and the council member, the college has contributed to this country 52,000 plus specialists, 40,000 the fellows and 12,000 the member. Currently we are having the maximum number of fellowship program, 88, and last month we notified another, so total 89 fellowship program and 22 membership program. These are the recognized institutions in Pakistan and overseas, mainly in UK, Ireland, Nepal and Saudi Arabia. The supervisor in Pakistan, outside the Pakistan, the number of the trainee in the country and the abroad. Now as far as your specialty is concerned, I think we did not have this much number a decade or 2 decades ago. Currently we are having 14 accredited hospital institutions in specialty of nuclear medicine. Similar is the number of the supervisor, 65 trainee, mainly in the public sector, followed by armed forces and the private sector. As far as provincial distribution is concerned, province of Punjab is number 1, 61, and 4 in the Sindh, and I think in other provinces the training is not, they have not been inducted. If you see the supervisor, they are 11 male and 3 female. Now there is a general shift towards the female as far as every specialty is concerned. In undergraduate 2 decades ago, the 70% of the students they were and they are female. But in postgraduate 2 decades ago, in postgraduate the female students they were 24%. 1 decade ago they were 48%. Now they are 58% the female ratio, the female students, and you can see the female in every specialty. In specialty of nuclear medicine, mashallah, 75% are the female and 25% are the male. So I think our daughters and the sisters, they are more hardworking and opting for every specialty in the field of medicine. अच्छा, मैं इसी का इंतज़ार कर रहा था, लेकिन ये मैंने जर्नल देखा है. जब भी मैं इस रेशो की बात करता हूँ ना कि फीमेल्स ज़्यादा आ रही हैं, तो तालियां फीमेल ही बजाते हैं. भाई आप भी बजा दो यार. नहीं, ये मेल जितने बैठे हैं, मेल. We had 7 centers in 2007 when WIN came, and currently we are having 14 plus 3 regional centers in every province of Pakistan. All these centers, they have got good video connectivity, which we are using for various meetings and various activities. This is one important slide which I just wanted to show you. This is 31st August this year, when in Karachi we were having 4 to 5 feet flood that was going on. And I was advised by the Karachi people to postpone the part 1 examination on that day. But I just asked them, since 1962, have we postponed our examination? They said no. I said, let the examinations going on. If the students they cannot reach, we can have another day of examination. But by the grace of Allah Almighty, when I monitored on my mobile telephone, on all 14 centers, 100% students, they were there. UK, Nepal and Saudi Arabia center, they were connected, and we did not receive a single complaint as far as the conduction of examination is concerned, when the country was facing the flood challenge, but CPSP activities, they are going on very smoothly. This is one important slide, जिस पे आप तालियां बाद में बजाएंगे, but this is one important slide. We are having the first fellowship examination, the 5 years, the second fellowship examined in 40 plus discipline, that is 7 to 8 years. And whenever we are having a second fellowship examination, I generally asked the word authority in those specialty, and we invite either the president of the Royal Colleges or their representative. The spine exam fellowship is a new fellowship. Last month we had the examination of this second fellowship examination, and I asked the faculty who is the word authority in spine fellowship. They said Max Abbey from Switzerland. He has been the head of spine fellowship program in US and Canada. We invited him as the external examiner in our examination. He said, I'll coming with the 3 more people. I said, no, it's no problem. Invite all these 3. 5 people, they appear in the theory examination, and 1 passed the theory. And that 1 candidate was examined by 6 examiners, 3 internal, 3 external. And in the end, I asked from Max Abbey, what do you think about the quality and standard of evaluation system of CPSP? His reply was very satisfactory. He mentioned that in US and even in Europe, we do not evaluate the candidate in second fellowship. We do the evaluation in the first fellowship, but we just certify in the second fellowship. The way you are evaluating in the second fellowship, your theory examination for cognitive domain, your talks examination for skill and professionalism, your long and short case, he said that is an example even for the West. I'm just sharing his feedback, that is 1 minute feedback after the examination of
well-reputed international examiners are the part of every examination of CPSP. There are 88 fellowship programs being run by CPSP, which include 46 first fellowship and 42 second fellowship. The first examination for spine surgery fellowship, that is second fellowship, was held on 12th of June 2025. International examiners who participated were professional examiners are the part of every examination of CPSP. There are 88 fellowship programs being run by CPSP, which include 46 first fellowship and 42 second fellowship. The first examination for spine surgery fellowship, that is second fellowship, was held on 12th of June 2025. International examiners who participated were Professor Max Abbey from Switzerland and Professor Michael Gravitt from UK. Next day, the spine surgery examination was conducted at CPSP Regional Center, Lahore.
I had the opportunity to be part of the examining team for the practical exam, from the clinical exam, and I was very impressed yesterday how this has been organized at the College of Physicians and Surgeons of Pakistan. Very well prepared for the candidates. That means with different stations, with major cases and with small cases to really see how the candidate can apply his or her knowledge to the practical confrontation with the patient. And I have to say that what I have seen yesterday is something I'm fighting for decades in Europe, that we have something like that. We don't have, you know. There is now, after a long discussion and things, there is some theoretical test, but there is no clinical assessment. And this is a big mistake, and I think I will go back and will tell them, go to Pakistan and see how they do that. That's what we have to do in Europe. Nobody is doing that in Europe in this way, you know. And, you know, I've worked also in North America for many years as a professor chair of orthopedics. And we have the Royal College of Surgeons of Canada, where you have exams, and where you also have exams with clinical cases, but it has not been systematized like you on it yesterday. And I can only congratulate you for what you started, and I really hope that this will come in real function for the whole country. And I was very pleased.
So his remarks, they were very encouraging for us. Coming back to the international collaboration, we have got collaboration with Ireland and the UK. After intermediate module examination or training in 13 different disciplines, they go to the Ireland, and in UK after intermediate and the fellowship examination, junior fellowship scheme and a senior fellowship scheme. Around 750 trainees they are working in Ireland and similar number in UK. And the principle of collaboration is that we are not the requestee, we are collaborator and we are partner. And whenever we go, we meet our ambassador and their ministers too, and we present CPSP case on international forum. Professor Amir Zama presented this accreditation system of CPSP, how we accredit the institution, what are the SOPs, and Professor Ricardo, who is the president of World Federation of Medical Education, he wrote to me, Professor Gondal, I would like to inform you that I had the opportunity to meet your colleague, Professor Amir Zama Khan, who made an excellent representation, not only of CPSP, but also of Pakistan. So by the grace of Allah Almighty, this institution is the ambassador of our country all over the world. Now coming back to the trust of international community, we are going to have a regular international conference on medical education in 2023. All the royal colleges, they were there, the health minister of all these countries, they were there. We had in 2024 and 2026 in February. In 2026, again, we are going to have the International Conference on Medical Education, and we have invited all the president of the Royal Colleges, and through Brigade Saab, we invite all these foreign speakers for this conference, do participate and be the CPSP guest. In last conference, the president of the Royal Colleges, they participated, Professor Brian Kiriram, Professor Raman Park, Royal College of Physicians Edinburgh, Royal College of Surgeons Edinburgh, and a few others. And they had an excellent feedback. Seeing is believing. They mentioned that quality and standard of this institution of South Asia and the content of this conference, they were happy and satisfied, and we received a good feedback from these people. We have got centers in Saudi Arabia, Nepal, Birmingham and Dublin, and the students and the residents, that is a win-win situation. We send after intermediate module examination our trainee over there, and they support their health and delivery system. Interview is either through the video connectivity or they physically come to Pakistan and take the interview. Against every one seat, they conduct the interview of 3 people. Selection is absolutely on merit base by those people. None of the council member or the office bearer is involved. Currently we are having 740 trainee working in University of Birmingham, Walsall, Leeds, Hull and Yorkshire. And when we have got a good number of fellows in UK, we had our own double-story building over there. We inaugurated on 14th August 2022, and the regular CPSP examination, they are going on at this center. That is 23rd March 2023. When we got 70 fellow qualified at this center, we had our own convocation, which was chaired by President College of Physicians in Pakistan, and on one side was Sarah Clark, President Royal College of Physicians London, Mike McCady, President Royal College of Physicians in Glasgow, and then the Edinburgh President, and all 5 presidents, they wrote on their website and they tweeted that we saw a good convocation of a good institution. And then we have been inviting regularly the president and leaders of medical education of the world to CPSP. As far as Ireland is concerned, we started this scheme in 2013. 19 students they landed. Last month I sent 106, 745 trainees. They have been exposed to this scheme, and we have completed 12 successful years, starting from 19, 106 last month. And we are going to have a regular meeting of the steering committee, the president of the Royal Colleges of Ireland, the member of Health Services Executive and CPSP delegate, and we always receive the excellent feedback from those trainers. The Prime Minister of Ireland in the last meeting thanked Pakistani government for their support in the health delivery system, quality patient care by the resident of CPSP, and the delegate was invited in the parliament, and Prime Minister was represented by the Minister of Higher Education, Helen McKendy, and whenever we go, one of the senior ministers receives CPSP delegate, and they thanked Pakistan and College of Physicians in Pakistan our own ambassador Aisha Faruqi in the embassy, and World Health Organization gave name to this scheme as a brain gain and not the brain drain. The reason is this is the control of college, that every candidate has to come back to Pakistan after completion of 2 years. They cannot overstay. If they overstay, that is a sort of brain drain which college do not believe. That is why the World Health Organization gave this scheme name as a brain gain and not the brain drain. And we received the highest prize of Healthcare Services Award, highest award, in 2017, jointly by CPSP, Health Services Executive, and then from UK and Ireland, we went to Middle East in the Gulf countries, because in Gulf country there was a competition between Pakistan and the neighboring country, and by the grace of Allah Almighty, now our qualification is top 2 qualification in the Middle East, and they have now announced the post, the candidate and the fellows having the FCPS qualification, they are being inducted as the consultant both on the clinical side and on the basic side. We signed this MOU 6 months ago, and our fellows, they are being respected over there. This is World Federation of Medical Education, and I think the people from west to east, they were there, and College of Physicians Surgeons was represented by myself and Amir Zaman Khan, and we were the keynote speaker in this World Federation of Medical Education conference. Last year again, the Jack Chamber, the finance minister of Ireland, he also awarded College of Physicians Surgeons Pakistan with the highest health achievement award received by the regional director, Dr. Sarfraz Mahmood Mir. This is just picture of last month. We had the meeting of International Association of Medical Regulatory Authority, of which the college is member, and the Secretary General of Saudi Healthcare Specialists, he invited CPSP delegate, and along with the Mayor of the Dublin, who thanked Pakistani government and College of Physicians in Pakistan for the feedback they are receiving from the public for the service which our trainee they are delivering in Dublin and even in the UK. This email I received in September, where the Health Services Executive Chief, he wrote to me, Professor Gondal, is an extremely interesting meeting of the delegation and hearing about the excellent and ambitious plans of training in CPSP. I want to commend you on overseeing such an impressive and thriving college. And I personally feel college is not the office bearer or the president, college of all of you, the fellows, the supervisor, the examiner, the trainer, and so many input because of you people that we are maintaining quality and standard at national and international level. All our activities, they are accredited by Accreditation Council for continued medical education, international accreditation, various prizes, and we feel the CPSP's greatest strength is not the example of power, but power of our own example. So ladies and gentlemen, thank you, and thank you very much for patient listening. Bahut shukriya.
Thank you, sir. Thank you, Professor Khalid Masood Gondal, for a very comprehensive overview of CPSP and its role in medical education in Pakistan. Now I again request Dr. Saima Muzahir, Vice President, Pakistan Society of Nuclear Medicine, to moderate the plenary session.
Thank you, Dr. Kashif. Now I would like to invite Dr. Ahmed Al-Jaziri. It's my pleasure. Dr. Al-Jaziri is an assistant professor of cardiology at King Saud bin Abdulaziz University for Health Sciences and consultant cardiologist in advanced cardiac imaging at King Abdulaziz Cardiac Center. Dr. Al-Jaziri is chairman of the Cardiac Imaging Working Group of Saudi Arabia Heart Association and director of the Advanced Cardiac Imaging Fellowship Program. Dr. Jaziri completed cardiology training at University of British Columbia, at the University of Calgary, and the echocardiography and nuclear cardiology at University of Ottawa Heart Institute. He holds multiple international board certifications and is a fellow of the American College of Cardiology and the European Society of Cardiology. Dr. Al-Jaziri.
Assalamu alaikum. Thank you so much for your kind introduction. I'd like to start by thanking Dr. Raza and Dr. Noman for their kind invitation. And I apologize for unforeseen circumstances. I couldn't be with you today. If you can kindly share my screen. Hello?
Yes, we can see you. Please carry on, Dr. Jaziri.
Yeah, thank you so much again for the kind invitation. So I'm going to talk about the role of anatomical and functional testing for chronic coronary syndrome and how can we choose among these patients. And I'll try to bridge the gap between the clinician and imagers. I have no disclosure related to this talk. Now, I will start with this case. This is a 61-year-old female with diabetes, hypertension, hypercholesterolemia, and osteoarthritis. She had recurrent episodes of chest pain on exertion with shortness of breath. Her profile revealed a morbidly obese lady with a BMI of 59. Blood pressure is out of control. She has unremarkable clinical examination. Otherwise, her labs were also a bit off. Her hemoglobin A1C was at 10.3%, which is her standard would be around 7. She has 3.6 of LDL, and creatinine was normal. Now, why do we care about chest pain? Chest pain is among the commonest presentation in our ER or even ambulatory care visit. 7.5% of patient visits to emergency room department in the US are related to chest pain, and 3% are in the ambulatory care visits are related to chest pain. Now, this may not seem a lot, but if you put them in the numbers, it is 7 million visit in ER and 2.6 million visit in the clinic. That's a total of, a total of 10 million visits, and you could imagine the impact of that on our healthcare system. Now, how do we risk stratify her? There are two questions. Does she need further testing? And what test should I order? This is how we as a clinician usually pause the question and then send the patient to imagers like you in order to help us to identify the cause of this patient chest pain and probably understand her risk in terms of cardiovascular diseases. Now, the first question, does she need further testing? And this usually goes to the pre-test likelihood of coronary artery disease. And luckily, over the past 30 years or so, we have a lot of risk model that tell us the likelihood of the disease. It started with Diamond-Forrester classification, which was published in the late 1970s, and it is a very simple approach. We look at the age of the patient, we look at the gender of the patient, and we look whether the patient has typical anginal chest pain, atypical anginal chest pain, or non-cardiac pain, based on the 3 criteria. And this will plot the patient into a risk of either low risk, high risk, or intermediate risk. Later on in the early 1980s, we have Duke clinical score, which integrated a bit of more information regarding the patient, including the ECG, hypertension, and diabetes. And it has similar approach, very simple as risk assessment in order to identify the likelihood of the patient coming with chest pain to have coronary artery disease. The problem of these studies that these 2 risk scores that they are very old and they are dependent mainly on coronary angiography and autopsies. And they have a bit of a different definition in terms of Duke framing, the Diamond-Forrester score consider 50% as significant stenosis, and while the Duke score considers 75% as significant stenosis. As you can see, there are also different range in terms of identification of patients in terms of low risk, intermediate risk, or high risk. Now, later on, we have the consortium clinical score, which has 3 scores: the basic model, the clinical model, and extended model. The basic model is similar to Diamond-Forrester model. The clinical model adds diabetes, hypertension, smoking, hyperlipidemia, and body mass index. And the extended model have add coronary calcium score. Now, as you can see, the problem with this score, it is a bit comprehensive and may be tedious to go around doing all of these numbers in order to identify patients that what are the likelihood of patient to have coronary artery disease when he or she presents with chest pain. We have also the confirmed registry risk score. This is a history-based risk score derived from registry, confirmed registry, which is the CT registry. And again, the problem with these registries is that they have a lot of parameter to look at. And in a busy clinical practice, it may prove difficult to put all these together before we can identify the likelihood of a disease of the patient. The updated Diamond-Forrester classification, or ORISCO score, is an updated form of the original Diamond-Forrester classification. It included people more than 70, and this time we have patients that have coronary angiogram, CT angiogram, with a better algorithm in order to assess the risk. But the beauty of it that it adds also patient presenting with shortness of breath as a angina equivalent presentation. And as you can see, the numbers are a little lower than those in the original Diamond-Forrester model, because now we have a better algorithm and we included cardiac CT. The European Society of Cardiology 2024 guidelines came up with the updated form of the ORISCO score that I just showed, and this time they added also the risk factors in order to better refine the risk of patient before decide whether they will or will not need the risk assessment. Now, if you go back to our lady, you will see that we use the classical Diamond-Forrester model, her risk is 51%. If we use the American College of Cardiology Diamond-Forrester model, it will be 27%. If we use the confirmed registry model, 17%. If we use the risk factor weighted clinical model, it will be 17%. If we use confirmed history score, it's 21%. And if we use the updated Diamond-Forrester model, it will be either 11% if we do not use the new European recommendation, or 14% if we use a European model. So most of the time, we usually try to risk stratify those patients that are higher than 15% likelihood of the disease. So one would ask, why not invasive coronary angiography? We just go to the gold standard, answer the question fast, and probably do this in a better way. The answer comes from this study, which is from the NCDR registry in the US, where they look at 2 million people referred for coronary angiogram, and when they excluded people who had prior MI, prior PCI, prior CABG, and those patients going for transplantation or going for valve surgery, or those patients who are presented with acute coronary syndrome, they end up with almost 400,000 patients, and only 37.6% of them have obstructive disease. So more than 60% could have been risk stratified otherwise without subjecting the patient to the risk of invasive coronary angiography. So now that we established that this patient needs a test, what test should I order? And in that term, 3 questions comes to mind. And those can be posed either by the imager or by clinician. The first question is, why does my patient have the symptoms? The second question, what can I offer my patient to decrease his symptoms? And the third question is, what can I tell my patient about his future cardiac events? Now, if you think of a chest pain, based on the diagnostic and risk stratification, we could go for either anatomical evaluation, which could be invasive, like coronary angiogram, or non-invasive by CT, or we could do for functional testing with stress ECG alone, stress echocardiography, nuclear imaging, which could be SPECT or PET, or stress CMR. And these are basically the overall view of how can we risk stratify my patient in order to get a diagnosis. Now, if we look at the diagnostic accuracy of these tests, this is a meta-analysis looking at per patient diagnostic accuracy on the left and per segment on the right. As you can see, PET and MRI lead the group with a very high diagnostic accuracy that surpasses the other modality. But in general, all of these have their advantages and disadvantages when it comes to risk stratifying patients. So if we go to each one of them, if you look at the test, CT angiography, you could see that we cannot provide a functional testing. We may add a pharmacological stress test in order to elicit ischemia. It has some radiation, definitely it has a contrast. Exercise stress test alone, It can be done with exercise. You don't need pharmacological stress testing. It has no radiation, doesn't need contrast, but unfortunately, it is very limited. It has very limited diagnostic accuracy of around 70%. The butamine stress echo could be combined with either exercise or pharmacological stress testing. It has no radiation, it has no contrast that affect the kidney, of course, but it has its own contrast that can be used. SPECT, it can be combined with both exercise and pharmacological stress testing. It's associated with significant radiation, and there is no need for contrast. But probably now with fluoroperidaz, we can do some exercise stress testing. However, it's mainly pharmacological stress testing. It has a better radiation profile, and it has no need for contrast. And CMR, we cannot do exercise. We can do pharmacological stress testing. It has no radiation. It has its own contrast, which is gadolinium-based contrast agent. Now, so basically, when we talk about the main two modality out of the non-invasive stress testing, we look at CTA, which is coronary CT angiogram, versus functional testing. And there are two studies that looked at the differences between these two modalities, which is the Scott-Hart study and PROMISE study. Now, starting with the Scott-Hart study, it's a pragmatic study of 4,000, almost 4,200 patients. They have low to intermediate likelihood based on the risk models that we've seen. It's pragmatic randomization based on the choice of the treating physician, and it compared a standard of care versus a standard of care plus a CT angiography. And this is the standard of care, including treadmill exercise stress testing for every single patient. The mean age was 57 years of age, good representation of females, probably diabetic are underrepresented. And as I said, all these patients had exercise stress testing and then randomized whether or not to have CT angiography. The outcome was very promising. Patient who has CT angiography has better chance of lower. The patients who had CT angiography has lower chance of cardiovascular death or myocardial infarction or stroke. Not only this, but patient who had CT had a better reclassification of diagnosis, change in the investigation, and change in the treatment. So very important in terms of changing the overall management of this patient. This has also been seen in 5 years follow-up, where again, patients who had CT angiogram has a lower chance of death from coronary heart disease or non-fatal myocardial infarction, and a better chance of, and less chance of non-fatal infarction compared to standard of care. Now, one would worry that this approach may lead to increase in the downstream utilization of testing, and this was not the case in patients who underwent randomization in Scott-Hart study. So you can see both invasive coronary angiography and coronary revascularization were similar in both groups, whether one was assigned to CT angiography versus standard of care. The PROMISE study was done on the other side of the Atlantic in the US and Canada. It included 10,000 patients, almost double the number of Scott-Hart, again, low to intermediate likelihood, pragmatic randomization, CT versus functional testing. Around 70% of patients underwent a nuclear stress testing, a quarter underwent a stress echocardiography, and only 10% underwent exercise ECG alone. The primary composite endpoint was death from any cause, non-fatal myocardial infarction, hospitalization, and major procedural complication. Mean age was 61, good representation of females and better representation of diabetics. And to our surprise, there was no difference in those outcomes whether one have choose initially to go for anatomical testing or functional testing. So completely the opposite of what Scott-Hart have shown. Again, likewise, PROMISE trial demonstrated that patients who underwent CT have a higher chance of cath, a higher chance of revascularization, and of course, lower chance of having obstructive coronary artery disease of cath. So exactly the opposite of what Scott-Hart have shown us. One thing that I like about PROMISE trial, that it has demonstrated to us that men and women are not alike when it comes to coronary artery disease. It showed that women have much higher positive stress testing, functional testing, while men have much higher CT abnormality. But interesting enough, when it comes to outcome, if a female has a positive CT abnormality, the chance of that lady having worse outcome is much, much higher. And this tells us probably that women have more endothelial dysfunction compared to men, and coronary artery disease, obstructive coronary artery disease that detected by CT probably is a very advanced phenotype in women, and that's why they have much higher outcome there. So why is the difference? First of all, every single patient of Scott heart has an ECG, and therefore if I see an intermediate lesion and the exercise is normal, I wouldn't send this patient to coronary angiography. Only 9% of patients of a Scott heart study have coronary artery disease, and the majority of these of events happen in those patients. Furthermore, Scott heart also imply a lot of preventive measures in those patients to have CT, and those patients who did not have CT were not recommended to have a preventive measure such as a statin and lifestyle modification. One final thing, Scott heart had lower chance of patient of typical and non-anginal chest pain compared to PROMIS, almost 1/3 extra. So probably PROMIS represent a more advanced patient with higher risk compared to Scott heart, and this is why we did not see the same presentation or same outcome that we see from Scott heart. Then one has to remember that the ischemia trial have also demonstrated that those patients with ischemia, with moderate to severe ischemia, do not do better if we use invasive strategy, and therefore one should think of doing in non-invasive stress testing, which is ischemia related rather than anatomy, without the fear of having missed a chance of giving the patient a better outcome. Now, what does European guidelines say? European guidelines say that if the patient has very low likelihood of disease, no further testing should be done. The patient has low likelihood of the disease, then probably CT is better. But as we go higher and higher in the likelihood of the disease, then one would probably choose functional testing. The American have almost the same recommendation. They consider younger patients with low likelihood to have better served with CT, while older patients with higher likelihood of the disease should have functional testing. And of course, if you are suspecting scar, then one would consider PET scan or cardiac MRI in order to further evaluate viability on the same setting. The arbitrary number of age is 65. However, this depends again, maybe modified based on your local expertise, because some of the time, and patients who have more prevalent of the disease, you could see calcification in a younger age, and you probably choose another test other than CT, because the significant calcification will preclude accurate assessment of obstructive disease. Now, what test should I order if we put things together? If you have suspected coronary artery disease, we will look at patient characteristic, likelihood of the disease, and availability of the expertise. Then if you are looking for rule-out strategy, basically rule out the disease and the likelihood of the disease is very low, then CT is your first choice. But you have to remember of coronary microvascular dysfunction. If you want to rule in the disease, so your likelihood of the disease is there is high, but you want to know whether it is obstructive or not, then one would ask himself, is the ECG interpretable? And if it is yes, then exercise, and the patient can exercise, then exercise stress testing with combination with myocardial perfusion imaging. If the patient could not exercise, then we have to resort to pharmacological myocardial perfusion imaging, which can be done with these modality, echo, SPECT, PET, and stress MR. If the ECG could not be read, then obviously we go directly for pharmacological stress testing. Now let's go back to our patient. This is her ECG, and it can be interpreted as you can see. And so all of these are options. She cannot exercise, so probably exercise stress test cannot be done, but we can do nuclear MPI, debutamine stress echo, stress MR and CT. She is big lady. She has a BMI of almost 59, so nuclear stress test can be done, but debutamine stress echo, stress MR and CT may not be a good option. She is obese. Then between SPECT and BET, we know that BET does a better job there. And this is her PET MPI, which showed normal, I'm sorry, I went fast on this, showed normal perfusion. As you can see here, good function with augmentation with exercise, good myocardial flow reserve, and overall, with this patient, pain was not cardiac in origin. So if we want to put this thing into summary, risk assessment in chronic coronary artery disease, there is a spectrum. I would probably start by getting the pre-test likelihood of the disease. If the pre-test likelihood of the disease is less than 5%, then probably should not do anything. We just reassure the patient. If the likelihood of the disease is less than 50%, so we are interested in rule out strategy, and the CTA is the best because CTA has the best negative predictive value of almost 100%. If I know that the patient has a disease, but I want to see whether it's significant or not, and this is most commonly happen in patient of more than 50% likelihood of the disease, then I will choose MPI. And one has to remember that either one of them could lead the other. And remember that in those patients who are at very high risk or very likelihood of having intervention, cath should be probably the best option. So in conclusion, ladies and gentlemen, non-invasive tests are versatile tools in evaluation of patients with known and suspected coronary artery disease. The choice of the test depends on patient profile, availability of the test on your locale, advantage and limitation of each test in regards to patient characteristics, local expertise. And finally, I want to share one final thing, is that in ischemia trial, where moderate to severe ischemia before enrollment were proven, 16% of subject has no obstructive coronary artery disease, and 52.6% of excluded patients have no obstructive coronary artery disease. So a lot of patients who were having significant ischemia did not have obstructive disease, and that should increase our awareness of ANOCA and INOCA, which will be my talk tomorrow, inshallah, if I didn't bore you today. And with that, I thank you for your attention, and I'll be happy to answer any questions.
Thank you, Dr. Al-Jaziri, for your very comprehensive talk. Now I open the floor for the question and answer session, and then we'll be heading towards a group photo. Yes, Dr. Arzu. There's a mic over there. Anybody who has a question, they can please come in towards the mic.
Head of Nuclear Medicine and PET-CT Division at Inmol Cancer Hospital. I would like to thank all the 4 speakers for very informative talks. But my question is pertaining to the talk that was delivered by Dr. Hussain Jadwar. It was an amazing 20 minutes or so because, in that talk, he covered almost all the challenges that a treating physician can face while using radioligand therapy. So I have 2 questions because earlier today, I also delivered a 40-minute talk in one of the workshops pertaining to lutetium-based radioligand therapy in treatment of prostate cancer. So there are 2 challenges that I am particularly interested in. Patients who present with diffuse bone marrow involvement. Should we not consider actinium in these patients upfront instead of first subjecting them to lutetium therapy? And number 2 is that in case of non-responders to lutetium, because like you mentioned, we should at least give them a chance with 2 cycles. But if after 2 cycles we responding, should we at that time consider going towards actinium therapy? And do you have any personal experience of using actinium? And what about the challenges involved in logistics and the side effects pertaining to the salivary glands and to the kidneys? That is the nephrotoxicity. Thank you.
Well, thank you for the question. First of all, I personally do not have experience with actinium. Actinium agents are not FDA approved. They are not available in the US, and also it is being essentially used either in clinical trials or for compassionate care in some other countries. So it is not mainstream. But to answer your questions, yes, if you have a if you have a disease, it because of the short range and very high LET, usually that seems to work better, although to make a final decision you really need to trial and see you know, what the efficiency and effectiveness is, and also what kind of toxicities will develop. With regard to xerostomia, it is a major problem with actinium or other alpha treatments, as you know. There have been several approaches to address this issue. None of them have really been the best at this point. The one that has been Mark Satheki from South Africa, who has, I would say, one of the people who have most experience with actinium, although there are also others in Germany like Clemens Kratochvil and others. They suggest that you should really use the higher dose at the beginning, like the first dose, and then you can kind of taper it down. So you kind of hit the cancer with the best shot you have, and then you try to bring the dose down in a de-escalation, in essentially a schedule, to, and it seems that that way you really can in some sense protect the salivary glands as opposed to give a regular scheduled same dose. Again, but these are all kind of anecdotal evidence in few patients, and we need clinical trials to really see, you know, if we want to use actinium type of treatments up, or, and if we are doing that, what kind of a schedule is the best?
Thank you, Dr. Jaffer. If you don't have any more questions, then in the interest of time, I would like the attendees for the group photo before we head towards exhibition and tea break. Before the group photo, I'll final call. Any other questions for our other distinguished speakers? Yes, please.
Yeah. This question is going to be addressed to Professor Bascom, and again, a very beautiful talk. And I think the take-home message was that now perfusion SPECT CT should take care of the question of pulmonary embolism. But for the CT component, I mean, do you have a radiologist sitting and reading? Because, you know, to understand or to read the CT chest, though been reporting PET CT for quite a few years, is rather a cumbersome procedure, and you need to be very diligent before you label it as any kind of pathology other than the pulmonary embolism.
I think it depends a bit on training. I think different countries have different curricula, and most countries now, our students are doing so much PET CT and SPECT CT that they are considered competent to read the CT scan. And certainly in the UK now, we're not expected to ask a radiologist. However, what I think our role would be is a little bit like the AI. I often, for example, on the nuclear cardiology reporting, which I did, I can't remember, Tuesday, wasn't it? Yes. I had 2 patients out of 5 that I was looking at who had previously unfound lung nodules, one which was 11 millimeters and one which was 13 millimeters. So this is on the CT component for our attenuated corrected SPECT CT, which is cheaper than buying cardiac PET CT. And what I did is that I recommended to the clinicians and wrote to the clinicians personally as well, saying, look, there's a lesion there, it's on a low dose CT. The first thing you should do is get a diagnostic chest CT and review by a chest radiologist of the images that I've produced to confirm that these are worrisome. So I'm not expecting nuclear medicine physicians to necessarily be able to diagnose everything, but what I would expect them to do is see that it's sufficiently abnormal that something further needs to be done. And I think that should be within our competency, even if we don't have a sort of instant second report by a radiologist. We should see enough scans in our training, both with PET CT and SPECT CT, to be able to say this isn't right, please get it checked out.
Thank you. Thank you.
Thank you, respected speakers. Thank you, Dr. Sana Mudahar, to moderate the session. Now I request Honorable Chief Guest to present souvenir to our esteemed speakers.
Actually, the chief guest has gone for prayers. As soon as he's back, we will start with the group photo and the souvenir distribution. I don't think it is going to take much time now, perhaps a couple of minutes more. I think we have a lot of senior people sitting here. So starting from those on the stage, may I request the guests of honor to share a few thoughts by the time the chief guest arrives, to keep you people entertained and to add to our knowledge as well. Thank you.
Obviously I will finish my talk as far as the chief guest arrives here. Just in a lighter note, I just want to say that, as you said, that give life to the years is a beautiful saying, as you said. So what I want to connect this to the BESCOM, that 1982, right, 42 years back, it was aerosols in Royal Free Hospital. Professor Dr. John Agnew and Dr. Cottrell, and we used to do aerosol studies, and I brought that equipment to Pakistan as well, the ambu bag and those kind of things. So in 42 years we have traveled so long that from aerosols we are now to the PET, CPPA and these things. What I see that in another 42 years, and maybe in 2064, 65, maybe we will be labeling COVID virus or some other virus and trace the lung anatomical studies, that kind of things. Because coming back to your that life, it is the nostalgic sort of effect that we have to see our past from where we start and how primitive things were, how advanced they are today. And another maybe 30-40 years where we will go, maybe that is the interesting thing to see. Once you are seeing the past and you are watching the future, that in the way they are going, that's just my, in a lighter note. Right, thank you.
Now again, request Honorable Chief Guest to present souvenir to our esteemed speakers. First, I request Dr. John Bascom to please receive his shield. Professor Hussain Jadwar. Professor Hussain Jadwar, please, sir. Yeah. सर थोड़ा सा डॉक्टर हुमायूं बशीर. Now I request Dr. Mehdi Raza to present a souvenir to our honorable chief guest on behalf of entire nuclear medicine community. And now President CPSP will present a gift to Executive Council and Pakistan Society of Nuclear Medicine.
This souvenir is on behalf of College Council and all the fellows in recognition of the contribution of your society. And President has just mentioned about the consideration of exemption of Part 1 for the people who have done already MSc. And I am going to take up in my medical education. That is consideration. Let us see how our Department of Medical Education and Curriculum Committee takes in that way. But I'll take that in a positive. Thank you.
Thank you very much. Professor Khalid Masood Gondal. With this, we conclude the inaugural session of the conference. On behalf of the President and the Executive Council of PSNM, I extend sincere thanks to our Honorable Chief Guest, distinguished guests, society members and industry partners for joining us and lending their support to this important event. I now kindly request all speakers, faculty members, organizers and society members to assemble for a group photograph with our chief guest. Please come on the stage. सर इधर से आ जाएं सर इस तरफ से सीढ़ियाँ उस साइड पे हैं और वो पीछे आ जाएं Following the photograph, we will accompany our chief guest to formally inaugurate the industry exhibition, which showcases cutting-edge technologies and innovations in nuclear medicine. This will be followed by a welcome tea at the adjacent exhibition hall D.
ਕਰ ਦੋ ਬਸ ਇੱਕੋ ਦੋ ਗੱਲ ਉੱਪਰ ਵਾਲੇ ਦੋ ਦੋ
Now we will move to adjacent hall D for welcome tea and industry exhibition. ਮਾਈਕ ਦੀ ਤਾਰ ਲਾ ਦੇ ਮਾਈਕ ਚੈੱਕ ਕਰਾ ਮੈਂ ਤਾਰ ਤੇ ਕਰਾ ਸਾਡਾ ਖੋਲੀ ਆਲੀਆਂ ਜਾਣਦੇ ਇਹਨੂੰ ਜਾਣਦੇ
Hello, hello, hello. Hello, 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 hello.